Okay, let me start. Or not. So tracheal airways. Pilbeam had a chapter, had some stuff in there on this. I did not see it in the new edition. They pulled out the airway management part, so you'll have to rely on Egan for your information. There's lots of stuff online as far as resources because we train patients' families to be able to care for trachs at home. Yes?
Is there anywhere where you can get the answers to the workbook questions?
They're online. You register and they
Okay. That's fine.
There you go.
Thank you.
So the performance evaluation that this is going to involve is doing trach care. We're going to combine that with a closed suctioning PE, so you'll do closed suctioning on our little bottle guy, and then you'll go ahead and do trach care and clean it both at once. We talked about the quid. So yeah, we're going to talk about as far as trachs are concerned, some of the terminology. There is a distinction between a tracheotomy and a tracheostomy. Whenever you see ostomy, you know if you have a stoma, you have an opening. The tracheotomy is the actual procedure you do to create the tracheostomy. It's semantics in a lot of cases, but it's technically a tracheostomy tube, not a tracheotomy tube. Okay? And it's sutured into place. So what makes up this tube? It's similar to an endotracheal tube, obviously. There's multiple brands out there. The one that we're going to have, that we have in the lab, is the Shiley. But Shiley and Portex are two of the more common ones you'll end up seeing out there. Bovona is kind of a weird trach in that instead of having a cuff that you fill with air, it's a cuff that is foam, and you deflate it to put it in, and then it inflates just by the foam expanding. It's kind of a different twist to it. And Mary will talk about that in the fall. Jack, that's the Bovona. It's a foam cuff. Jackson is a metal trach, and we'll talk about them in a little bit too. Pardon me? So this is what you're going to be playing with, your tracheostomy tube. It has a pilot valve, just like the endotracheal tube, an inflation tube that's going to the cuff. Cuff is exactly the same design. This tube has a flange that is kind of a stiffer plastic that allows us to go ahead and have our tie strings to secure. Okay? We're actually not going to use tie strings. We're actually going to use a Velcro. I'll show you in a second, so it's a little bit easier to manipulate. But within the kit, within a trach box, it would have the tie strings there. There is actually two tubes built into one. So there's an outer cannula. You can see that's the rigid part that is placed inside the neck. Then there's an inner cannula on most of the trachs that you're going to encounter. And the inner cannula is removed and cleaned. Or it's removed and thrown away and a new one is put in. Depends on if you have a reusable inner cannula or a disposable inner cannula. And the final thing is an obturator. When I'm first putting in the tracheostomy tube, and one of the skill sets that you should have by the time you graduate is not only caring for the trach, but if you needed to replace the trach. It's actually quite easy on a patient, and not the first time it needs to be replaced, but long-term wise. Some of the kids you'll see at camp, they've had a trach for 4 or 5 years. That stoma is pretty well granulated over, so it's basically just a permanent hole there. So to put a new trach in or out is quite easy. Fresh trach is a different story. Fresh trach, the possibility exists to get this tube not into the trachea, but into the soft tissue between the trachea and the outside. Especially if I got a guy who's got a size 22 neck, he's 400 pounds, it's quite easy to lose the stoma. Okay, so you got to just be aware of that. But the obturator is a device that has a rounded tip, and what it does is it splits the skin to make it go in. Okay, so whenever you're putting a new trach in, you would use the obturator. Yes.
That hollow inner cannula is what goes inside
The outer cannula.
Okay.
You betcha. So why do we do trachs? Sometimes it's needed for patients who have upper airway issues. Okay, either laryngeal tumors, maxillofacial injuries that are significant, long-term management of a patient with lots of secretions, and that says 14. I would even go a little bit less than that as far as 2 weeks, especially if I got somebody who is like a Guillain-Barré, who I know is going to be on the ventilator for a prolonged time. They'll even trach them earlier than that. Okay. And this is out of Egan. Like I said, most sources will pick 14 as opposed to 21 days. But it's just an evaluation each day. Can this patient be extubated? No, no, no. And maybe we better consider traching them because they're not strong enough to be ventilating on their own. It's going to be a long-term management. Endotracheal tube you don't want in for a long period of time. Let's go ahead and trach them. Okay. So how do we put them in? Well, it's done typically, and all we're going to concern ourselves with at this point in time is a surgical procedure in the OR. There is a special type that Mary will talk about in the fall called a percutaneous trach, which is done to bedside. Okay, and it's kind of a, if you ever see it done, it seems almost like a cruel procedure, but what they do is they make a small percutaneous puncture of the trachea, and then through a series of dilators make that hole bigger and bigger and bigger. It doesn't sound good. No. They sedate them.
Yeah, they got a good one on YouTube.
I'm sure they do. It's quite graphic. Yeah. Yeah. And obviously the tracheostomy is something that can be done in an emergent condition if needed. This is the procedure of the surgical, what they do. If you look at creation of it, Chevalier Jackson, 1909. So been around a long time as far as the technique involved. But it's typically somewhere between the second and third, tracheal ring is where the trachea is done. Notice there is a recurrent laryngeal nerve that runs right along the side of the trachea, and it's one of the complications that occurs is that nerve becomes damaged. Okay. In that case, what you end up with is that recurrent laryngeal nerve feeds the larynx, so you end up having vocal cord issues. Here we end up having, you can see that I've now created an incision, or the surgeon's done the incision. They're going to go ahead and, with the obturator in, okay, here's my obturator. That inner cannula is not in, rather that obturator is gone, and the tip now is a little bit smoother, and we can go ahead and insert it so the trachea is in. Once it's in, I can pull the obturator out and put the inner cannula in and inflate my cuff. Okay. And you can see we're now below the vocal cords, so these patients can't speak because there's no air passing through the vocal cords. Okay. Now there is a specialty tube, special tracheostomy tube called a fenestrated cuff, where there's a fenestration, there's an opening right here, and I can deflate the cuff, cap this off, and have the patient vocalize and talk. At night they need to go back on a ventilator. I pulled the cap off, inflate, put the inner cannula back in so the fenestration is not open, and go ahead and inflate the cuff and ventilate. Kind of has the best of both worlds. And Mary will cover that in the fall. Yes?
You inflate the cuff the same way as...
Same way. Yep. Yep. Minimal occlusive volume. Measure the cuff pressure. Yep. Early on, during the surgical procedures, obviously it's a surgical intervention, so there's always the chance of bleeding happening. There's always the chance of cardiac arrest happening from inability to ventilate. The trach itself, depending upon its placement, may not be placed properly so that you can end up having an obstruction, or what will end up happening, because you're thinking about this is just sitting inside the trachea, kind of just hanging there. You can also have it so that the distal tip of it is actually rubbing against the posterior wall. You get some erosion. So it can end up happening. Long-term wise, just due to management, that cuff being inflated, again, if it's the inappropriate amount of pressure that is in there, you can end up with a tracheal malacia, tracheal stenosis, the development of granulomas, or that tracheoesophageal fistula, long-term wise. And, you know, post-tracheostomy, depending on how long that trach has been in, you can get some scarring that ends up being there. So why do we do them? Well, you don't have the problems of the tube going through the vocal cord, so long-term wise, those tissues don't get damaged. It's a lot easier on the patient to have a trach than to have an endotracheal tube in place. I mean, reading lips, being able to communicate, a whole lot easier. When you see the kids at camp, they actually don't have cuffs on their trach, so they'll use Christopher Reeves, if you remember, he would talk. Well, how the hell is he talking? He's got a trach in. Well, he had a leak. So when the ventilator pushed air in, some of that air went to his lungs, some of the air came back up through. So if you watch him if you see film of him talking, he talks for a little bit, and then he talks a little bit more, and he talks a little bit more. But there's a pause there because he's got to exhale. He's got to wait for the ventilator to cycle again. It's a pretty neat idea. It can be reinserted quite easily through that stoma. Like I said, especially once that early period has passed. You can wean from the ventilator on a much longer term without having to have that complication of the tube. There's no problem with main stem. The tracheostomy tube is not that long, so you're never going to have a situation where it's going to enter the right main stem bronchus. Less dead space, because now I've eliminated all this anatomic dead space, so it's a little bit easier to ventilate. Yeah.
So, what determines whether you get a tracheostomy or endotube?
Well, initially we're going to do an endotracheal tube because that's the easiest to do in an emergent situation. Okay? Assuming there's not some other bizarre situation going on. Once I have that tube placed, then I make the decision, can I get this patient off the ventilator and get that tube out, or do I need a long-term airway? So if it comes down that I need to have an airway long-term, then I need to be trached.
The 21 days thing, or?
Yeah. Well, let me rephrase that. If I know going into the case that I have a patient that's going to be requiring long-term ventilation, I'll trach earlier than that. It's not that I have to wait for the 14 to 21 days to happen. Yeah.
So let's say it's an emergency and how do you just, I know you just said you would intubate, but...
Unless there's some reason that I can't intubate because my, I have a gunshot wound to the jaw. My mandible is just a mangled piece of mess.
What about for choking or something stuck in?
Well, if you got an airway obstruction, you need to get rid of the airway obstruction. If it's upper airway and you can't do it, that's where you could do. You probably would go to a cricothyrotomy. It's kind of opening up a whole other pathway here. But if there's something that you have a physical obstruction and you can't get at it, yeah, that's why we would do a cricothyrotomy, or in theory a trach. But trachs are a little bit, you really want it to be a little more of a controlled condition. Okay. Cool? Yeah, disadvantages. A little more expensive as far as the piece of equipment. Might have to use the OR to do the insertion. We talked about the percutaneous. That is an option. But you're taking up OR time, taking up a surgeon's time, taking up anesthesiologist's time, so there's costs involved there. You can end up, I mean, it's a permanent scar that you're going to end up having at somebody's neck. Okay. More severe complications can occur as far as the tracheoesophageal fistulas and the tracheomalacias, which leads to a greater mortality than the simple endotracheal tube. It can be hard to decannulate, hard to remove the tube. More chances of infection. It's an open wound. It's an open sore that you have. Okay. Difficulty generating enough pressure to cough. And I say that, and of course you're gonna walk in and have a patient who can hock a loogie quite well, thank you very much, when they're being suctioned. So don't stand in front of the trachea. Always stand to the side. Do this. So loss of Valsalva maneuver, loss of sense of smell. We talked about that above. The endotracheal tube also. Loss of communication. Although it's better than endotracheal tube, it's certainly is something we need to be aware of. Sizing of an endotracheal tube is pretty easy. If I said I had a 7 millimeter internal diameter, that's pretty obvious. Now a trach. Trachs kind of don't follow that pathway. The tube number, a number 8 Shiley, does not mean that it's 8 millimeters internal diameter. Okay? You got to really look at the box to know what size it is. So for our purposes, I'm not going to concern ourselves with it. On the Shiley, when you look at them, you'll see it'll say this is a size 8, but it's a 8.5 internal diameter. So you need to know what the internal diameter is to determine the proper size suction catheter. Make sense? And how do we measure suction catheter size for a tube?
Take the 2 times 3 divided by
Inner diameter times 3 divided by 2. And then you go one size smaller if that size doesn't occur. So I think that you probably should memorize this. I'm kidding. But you can see that the Jackson size is the size that the trach tube is. So if I said I had an 8 trach, that means an 8 Jackson, which is really 8.5 inner diameter. Sorry, it's the way it is. Now these letters, DCT, DFEN, LPC, FEN, CFS, CFN, what the hell does that mean? Disposable inner cannula, disposable fenestrated, low pressure cuff. They actually do have a meaning for them. For right now, don't worry about it. It's a trach tube with an inner cannula. The inner cannula, as I said before, and this is the only thing you need to remember about it, the inner cannula can either be disposable or be reusable. If it's reusable, which is what we have in lab, because we want to take the harder one first, the reusable inner cannula has to be cleaned each shift. The disposable inner cannula is disposed of. You just swap it out. Throw away the old one, put a new one in.
Each shift?
Usually each shift, yeah. Yeah. Unless it's soiled for some other reason. And this is just off the Shiley website, but you can see there's a difference between the inner diameter and the size. So an 8 is only 7.6 in this case. Oh my God. And these are the two that you'll probably see the most often, the low pressure cuff, which is just a reusable inner cannula, and the disposable inner cannula. You don't need to know the names. Okay? I just want you to recognize that an inner cannula can be reusable or disposable. You can have a cuffless trach. You can actually have a single cannula trach that doesn't have an disposable inner cannula. Get grungy. Okay? They make them extra long, both extra long this way, as far as the neck, or extra long this way. So either the proximal end or the distal end of the tube is longer. So if I end up creating, if I end up having an area where I have some tracheomalacia and I have difficulty getting a good seal, because the wall of the trachea has become sponge, I can go ahead and get a trach that's a little bit longer, so the cuff's down a little bit further, and get a seal, and create a second point of tracheomalacia. But that's beside the point. Fenestrated tubes are the ones with that opening, and again, these at the end here, Mary we'll talk about. Those are the two we're going to concern ourselves with. So how do I know what size it is? Well, I look right over here. Right on the flange, it'll say that this is an LPC size 6. LPC means it's a reusable inner cannula. I'm going to swap out. Here's what the disposable cannulas look like. It has a little flange on a little mechanism on the side that locks onto the flange. You just squeeze the tabs, and it releases it. To put it back in, you just click. Trach tubes are, like I said, there's that the tape that, or not tape. It's cloth ties that comes. It's like a shoelace that comes with the kit. They're initially sutured into place, so when you first come back from the OR, there's going to be some sutures that are there for the first week. Obviously, we're just going to leave them alone, clean around them, but those are in place until the surgeon feels that the tracheal stoma has matured enough to pull the sutures out. It's usually about a week. Then we'll go to some kind of either cloth tape. I use the term tape. It's called umbilical tape, and it actually was the cloth that we would tie off the umbilicus with at one point in time. It's not really tape. It's like a shoelace, like that. Or we'll go to our Velcro trach ties, which are actually far more convenient to use. And just like the endotracheal tube, voila, don't let go, because they'll cough it out. Here's what the Velcro looks like. And when we get to the lab, I'll show you how to do the adjustments there. But this little white portion here is actually pulled through the slot and is allowed to come back and attach to the Velcro. This is just another one. This happens a lot where long-term ventilation, patient will cough and the thing will come disconnected. So this is a little tying mechanism that goes around the ventilator circuit, so it kind of holds it in place so it doesn't come popping off. I don't even know if we got an example of that in the lab or not. So here's the important part. We need to clean this periodically. We need to do both some wound care, some stoma care, make sure that stoma is not becoming infected. And then we'll also have to clean the inner cannula or change it out if it's a disposable. Change the trach ties because they get grungy. Change the dressing that is there. And then do our normal tube cuff assessment. Make sure that the cuff pressure is appropriate. Make sure that the tube is in the proper spot. You know, a big leak. Okay. So what do we need to have? Well, kind of similar to what we have for the suction equipment. We are, as part of this, going to be using the closed suction system. So the patient's already going to have that in place. You're going to have to work around that to change the trach. We'll need not only sterile water or sterile saline, but we'll also need some hydrogen peroxide. We're going to use that to clean the wound itself and to clean the inner cannula. You may need something like some bacitracin to end up having, if there's some sign of redness, you can apply some to the topical antibiotic. We always want to have, although we don't have here in the lab because we just don't, but you should always have a second trach at the bedside. And that usually is protocol of the hospital. If they have a patient who has a trach in, there's a second one that is in the drawer in the bedside table. Resuscitation equipment, syringe and stopcock, and our little kit that's a trach care kit. If your cubby isn't full yet, it will be after today because we'll give you a trach care kit. Okay. There's a drape for a sterile field. There's multiple basins, at least 2, sometimes 3. A 4x4 gauze. There's a trach dressing with some twill tape. That twill tape is that shoelace I was talking about. Some swabs, some cleaning brushes, some pipe cleaners, and some sterile gloves. Because this is a sterile procedure. So initially you're going to need to do it a little more often, but eventually it's like every 8 hours, just like a shift change. Okay. Patients at home, we probably do a little bit less frequently just because they're much more stable. So they'll just do it probably daily care. Okay. Make sure the patient doesn't need to be suctioned. So one of the things you'll do to begin this PE, this combined PE, is to use the closed suction system to demonstrate that. There's nothing worse than getting this trach care all done and nice and clean, and they cough a big loogie through. It's like, man, I just cleaned it up. And it's like having a baby and you just change the diaper and they go and they dump a load again. It's like, really? Okay. And we're going to, there really is, if you're ventilating a patient or having a patient breathing spontaneously, there's a little bit of a difference involved. Obviously, if I have a patient breathing spontaneously, they can still breathe through that tracheostomy tube while I'm working. Patients who are mechanically ventilated are a little more, you have to be a little more cognizant of timing involved. So we're going to remove the old dressing and dispose of it. We're going to take a look at our tube, make sure that we have the proper size inner cannula, as a spare inner cannula. We're either going to have a disposable or, again, that reusable. If I have a reusable, there's a spare reusable that I can swap out. So I'll take my old one out, put my new one in, clean my old one to be used the next 8 hours. So I'm just rotating them. Okay? If it's disposable, it's a whole lot easier. Just pitch it. Okay? And then we'll take a look and see about the stoma itself. So once I have the dressing off, I can assess where that trach tube has gone in, and is the area red or have some swelling there. So I always want to make sure we talked about the spare trach tube. You should be able to distinguish between a disposable and a reusable inner cannula. And if it's a reusable, I'm going to have a spare one there to rotate in and out. If it's a disposable, it's a whole lot easier. So I go ahead and I open my water, open my peroxide, and then open up my sterile kit maintaining a sterile field. Put on the gloves just like you did for suctioning. And I'm going to use it then, the trach kit has an actual drape that you can lay out to keep a sterile field. It's got the basins there. I'm going to fill one basin with my sterile water or my saline. The other one I'm going to have some peroxide, which I'm going to mix 50-50 with water saline, with water or saline, so it's not the full 3%. If I have a third one available, you can leave that one empty to store stuff in. I'm going to go ahead and clean the surgical wound itself by using a cotton swab dipped in the peroxide to clear around that area. You always want to move from the center outward, away from the wound center. Once I've done that, I can go ahead and, again, we're not re-dipping. It's just like eating chips with your family, no double dipping. And use the gauze then to go ahead and clear around the wound and dry it off. If I have my disposable inner cannula, I'm just going to go ahead and squeeze the tabs, pull it out, throw it away, put a new one in. You're not that lucky. You're going to have a reusable inner cannula that we're going to go ahead and have to clean. So with the inner cannula, the way they work is it slides in, and then the very top of the very end of the inner cannula has a little clicking mechanism. So it rotates and clicks into place. And when you play with it, you'll end up seeing what I'm talking about. You turn it counterclockwise to release it, and turn it clockwise to click it into place. So I'm going to pull the old one out, put it in that third tray or in an area where I can clean it, put my old one I had and put it back in. So now I got the patient stabilized with an inner cannula, and I can have them put the oxygen back on while I'm cleaning that other inner cannula. So I got the one that I want to clean and soaking in the peroxide. I can go ahead and clean any debris out of the actual trach opening if there is anything there, and usually there is not, but there might be. I'm going to go ahead then and clean the cannula with a peroxide solution using, there's a little brush and a little pipe cleaner. Just kind of clean it out, the core of that, because what'll end up happening is the secretions will actually start to get crusty on the inside. Rinse it with the sterile water, shaking off the excess, and if you didn't have the rotation process going on, you could put that one back in again. For our purposes, we'll just rotate between them. So we're going to put the cleaned one in a spot so we can use it next time. And this is just talking about having that spare cannula to be able to ventilate the patient while we're cleaning. Then I need to clean the trach tie, or replace the trach ties. So again, every 8 hours they get brand new trach ties because they're going to get saturated. So when you attach the Velcro, you want, or the trach shoelaces. I hate to use that term, but I don't get anything else to say for it. You always want to have a little bit of a give. You don't want it so tight that you're cutting into the skin, but you want it tight enough so that the trach tube doesn't fall out. So usually 2 fingers under the tie, if you can fit 2 fingers there, that's enough of a give. Okay. Yeah, and if you're using the umbilical tape, you want to tie it into knots, not really pretty bows. You don't want it to become loose. Okay. Take a look at that area of the wound, make sure that it's not red, and then I'm going to have to replace the dressing that is there, the gauze dressing. The trach dressings are, you guys all know what a 4x4 gauze pad looks like, right? These are specialized gauze pads that have an area cut out from, it's like a box with an area that's cut halfway in, okay, so that it can fit around the trach tube. Okay, you can't cut gauze and make one, because when you cut gauze, you have these bazillion little filaments of cloth that make a mess. So you're going to use a pre-made trach dressing. There we go. I said it. Okay. And then finally, once I get the dressings placed, we'll go ahead and check for cuff pressure, make sure the tube is an appropriate place and everything's okay as far as that is concerned, and then make sure that we're humidifying appropriately. And that's it. Cake, right? So, page 80 has the lab on this, and those are the 5 steps that you're going to need to walk through. So why don't we go and I'll do a demo of this, and by that point in time it'll probably be close to 11, and we can go ahead and break for lunch and be back at 12:30. Okay? Or 12:15. 12:15. Johnny, do you have a question?